Now moving on to another dimorphic, I want to invite Ana Belen Arauz Rodriguez, who is going to tell us about histoplasmosis in Latin America, and more specifically in Panama. So, thank you.
Hello. First, I would like to say thanks to the organizing committee for this invitation and having the opportunity to talk to you about our experience with Histo in Latin America and more specifically in Panama. So first, we're going to start with a clinical case from my hospital. This is a 33-year-old woman recently diagnosed with HIV. She came because of fever, dry cough, asthenia, pruritic chest pain, and she was losing some weight. Her labs, anemia, and this is the chest X-ray. When we saw this chest X-ray, we thought, okay, this is TB, most probably, so let's start her on anti-tuberculosis treatment. Then on the second day, she developed abdominal pain with increased amylase and lipase with an ultrasound that shows pancreatitis. So she was then on broad-spectrum antibiotic treatment, trimethoprim sulfa, just in case there is pneumocystis there also, and the anti-tuberculosis treatment was skipped. So on day 6, the lung infiltrate got worse, and then we were able to see that the platelets went down. And that is when the clinician thought about Histo in this patient. She was started that day on amphotericin B, the oxycolate, that is a standard of care in Latin America. And even so, she ended up in mechanical ventilation on day 7, and we are going to go back to the case later during the presentation. So first, we're going to speak a little bit about the historical perspective of Histo, the epidemiology in Latin America, what are the advances in diagnostics in the region, the problem between Histo and TB, and some of the treatment challenges that we have. So if we're going to talk about Histo, we need to talk about Samuel Darling. And actually, he described the first time Histo in Panama. He was a military working in the construction in the Panama Canal. And it's funny because from the very beginning, there was this confusion between Histo and TB. People thought this patient had miliary TB. And then Samuel Darling did the observation that it made a new pathogen in this person. So the global distribution of histoplasmosis, as you can see here in this picture, is across the entire world. We are going to focus on Latin America, but of course there are some cases in Africa and Southeast Asia and Australia. I was speaking with somebody here, and he was telling me about the cases that they have there. So why is histoplasma a problem in Latin America? So as you can see here, these are the stories of skin testing for with histoplasmin for prevalence. It's definitely under-recognized. There is lack of diagnostic tools. That is why this meeting and being you here is so important. There is a greater burden of the disease, especially with the AIDS, HIV epidemic that is still not under control in our region. We are still seeing many cases of histoplasma. And as we have been saying, the tuberculosis similarity is also another barrier in this disease. So I just would like to say that Panama this year now is supposed to be a high-income economy. I don't know how, but that's why it is. But in reality, this is what you see everywhere. There's a lot of inequality in the entire region. And I am scared of losing the help that we are getting from, especially from the US right now by the CDC, to get more diagnosis in Histo. So that's why I'm a little bit scared in the region. So for the clinical spectrum of histoplasmosis, we all know that most of the cases will go asymptomatic. Some will go for acute pulmonary disease. This usually is unnoticed in our practice because we don't have enough diagnostic. But what we will see will be the progressive disseminated disease in the immunocompromised host, especially HIV/AIDS. Histoplasmosis is only an AIDS complication? Definitely not. It is also a problem, especially in solid organ transplant patients and TNF necrosis blocker therapy. But there is lack of data from the region of how this is impacting the few transplants we still do in the region. I just put here a clinical case that we have in the hospital on a young patient. She was a 24-year-old female. She had Evans syndrome. She had an splenectomy. She was on prednisone 20 milligrams per day plus rituximab. She came to the hospital with respiratory symptoms. You know what we thought first, right? It was TB. So she started treatment with TB. It was not until the day 20 in the hospital when she got worse and the platelets went down and somebody did a peripheral smear that you can see there the small G's inside, intracellular G's, right? So then the histo diagnosis was made and she started on treatment, but she was not that lucky. So histoplasmosis is a multi-phase disease, and we see this in our daily practice in Panama. And what is special about histo in Latin America compared to what you see in the US is that we see a lot of skin affection in our patients. You even walk into the emergency room and you see the patient with the lesions in the skin. You say, yeah, this is histo until proven contrary, right? So this is also, of course, the lung you will see in TB versus histo. And we also, for us, it's also important the gastrointestinal presentation of these patients. This one has colitis by history. There is another interesting history behind this picture where we don't have enough time to talk about it, right? So there have been a few cases series that have described histo in Panama. This was done in the other main hospital in the capital of Panama. And then we try to get a little bit of our own hospital, Hospital Santo Tomás. So we did this review of 5 years of what's going on with histo in our hospital. And what caught our attention is that only 10% of the patients that we were treating as histo had a positive blood culture. And most of our diagnostics was relying on histopathological studies that, you know, in my region takes maybe 20 days to get a result. So usually we were diagnosing people late, and I don't know if it's because of the patients we had access to, the mortality in this study within our hospital, it was 59%, that was pretty high. So what happened in the region related to mortality is high. It may go up to 40% for example, in Guatemala. But again, we have to remember that this disease usually goes unrecognized in our region. And what can we do to deal with this? Definitely we need good diagnostic tools. And these are all the things we have available or supposed to have available. But in my hospital, in the beginning, we only have these 3 first diagnostic tools available, and they all took a lot of time to go back. So we use a lot of clinical expertise to start empirical treatment very early in these patients if we think about histo. But of course, what we are always asking for is we need especially the antigen tests, considering our principal problem are the disseminated disease. And these antigen tests, especially in the patients with disseminated disease, have a pretty high sensitivity, above 90%. Of course, I hope in the future, we will take care more of these other presentation that we may have in our practice. But honestly, we don't see this like almost never. When we see histo, it's usually in a patient with AIDS, in the progressive disseminated form. But we need more, not only the antigen, but use a combination of tests. I was telling yesterday, Dr. Witt, about the combination of the antigen, antibody, especially in CNS disease. So, but we are going to concentrate in the antigen because HIV/AIDS and mortality for histo is most important there in our region. So talking about the antigen test, so it is available since 1986, especially in the US. In the year 2008, there was a study done actually in Panama proving that this antigen work in Latin American population. But basically, during 23 years, there was no real access for Latin American region to the antigen test out of cost, and you have to send the samples to the US. So thanks to an initiative from the CDC where they developed this polyclonal ELISA antigen in urine, and they use it especially in Guatemala and Colombia during these years, that reality starts changing. And the Colombian experience shows that how the access to this diagnostic tool have increasing a lot the diagnostics of histoplasma. So this meeting was crucial for Panama. In 2015, we were invited to this meeting. I met Tom and Eduardo Araton from Guatemala. And I met a lot of Latin American people there, and we were all asking for the same thing. We were desperate, seeing our patients dying, and we all got to the conclusion that we need a better diagnostic. So there is this histoplasmosis advocacy group that the goal is to, by 2020, get at least 80% of capability of diagnosing histo in the region. So thanks to this initiative, now I can say that we have kind of access to the antigen test in the urine. I'm going to talk a little bit more about it later. But this is how this is going further in this initiative. So talking about the patient that we start at the beginning, we can see that on day 7, we got the urine the antigen positive and the TB gene expert negative. So at the end, she did well. We stopped the TB treatment, so it was all histo in this patient. But why day 7? Because we are only running the ELISA once a week. We may be trying to do it twice a week, but it's only one a week. So if she comes like in a Tuesday and it was run on Monday, this takes a lot of time to get the diagnostics. So this is how this initiative is progressing in the different countries. Now my country is in red, but I'm concerned about that because only this red actually belongs to my hospital, Santo Tomás. The people from Caja de Seguro Social, who made the first paper in 2000, actually they are not using the test. And there are so many other areas in the country with really low cases reported, but we know there is a lot more histo in the country. So the next challenge is to get the test to all of these places in our country. So what about histo and tuberculosis? Why this is a problem? Similar clinical symptomatology, treatment interactions, and high mortality. This is a paper from French Guyana, where they try to do how both diseases are different through clinical and laboratory aspects. It's very difficult. If you think pulmonary, you will think TB, but it may also be maybe histo. And they try also to do it with the labs, PCR reactive elevated, maybe more tuberculosis in that patient. But this is very difficult. I would love to have a clinical score that I just go and see the patient and have a guess. But honestly, what we really need is rapid diagnostic in this population. So this is the problem. The TB co-infection in people with histo is also high. So as you can see here, in Guatemala, it gets to 10%, Colombia, 35%. And the other concern is that there is a high mortality in those patients diagnosed with culture-negative TB. And people who do advocacy for histo says that most of these patients that have been dead out of TB culture-negative, most have been histoplasmosis. And this is a very nice paper that was just recently published in Lancet Infectious Diseases, where they did these mathematical, complicated estimations, trying to see what is the real burden of histo, because if you look for it, there are not too many cases reported. But when they did this estimation out of prevalence of skin testing, the HIV incidence, the percentage of these HIV patients with less than a 200 CD4, they came to the conclusion that people in Latin America may be dying even for histo compared to tuberculosis. And always our public health authority will be concerned about tuberculosis, and they are not thinking about histoplasmosis. And what about mortality in Guatemala? I just brought this Kaplan-Meier graphic because it seems very interesting. You will think that if somebody has TB and histo, there may be more mortality. But in this study they done in a cohort in Guatemala, when the patient only had histo, the mortality was worse compared with those co-infected with TB. And they start doing some hypotheses that if you have TB, you may have more TNF or interleukin-12 or interferon gamma, and those may be controlling the histo in that patient, but this is only in the hypothesis level. So what are we doing? This is Panama, and this is the lab, and this is Diego Cáceres, who have been doing most of the work in our country. These are the rapid diagnostic we are using right now that is being provided by the CDC, the monoclonal antigen from IMI, the ELISA. And in the last 2 years, we have been basically doing the surveillance for histo in every patient that gets into my hospital with AIDS. We run the test. And in the last months, we have been doing retrospectively, adding the TB LAM to see if these 2 rapid diagnostic tests may help in identifying TB versus histo patients faster. And this TB LAM, as you know, the specificity is pretty good, and the sensitivity will be dependent on the level of CD4, and the median level of CD4 of the patient of the patients I get into my hospital is around 50, so this must be working fine. So this is the hospital, and out of 500 patients tested in about 2 years, 27% of them are histo positive with the antigen, and 20% are positive with TB LAM. Of all of the 500 patients, practically there is a 10% co-infection in the cohort. But what caught my attention is that those patients with histo, 25% may be co-infected with TB, and especially TB because you have a patient, you diagnose TB, you have the TB in the gene expert positive, you stop pursuing another disease if the patient, especially the patient is getting well. But up to 30% of the patients that were positive for TB had also histo. So I think in this population, especially is where the urine antigen is crucial for them, for us to start treatment before they come 1 month later, now with the Arauz for histo. Treatment is also a barrier. We use amphotericin deoxycholate with all the toxicity. Usually, we may need to keep them on amphotericin B for secondary prophylaxis once a week or every 2 weeks, either because they don't have access to itraconazole or because of drug interaction. If they are receiving treatment for tuberculosis with rifampin, the itraconazole levels are not going to be reliable, and we don't have how to measure drug levels. And we try to use the primary prophylaxis in the patient, but again, it will depend on the patient accessibility to the drug. So the main challenges in Latin America for treatment is the availability of drugs. It's funny, but when we got the antigen in the hospital, guess what happened? All of a sudden, there was no amphotericin B. So I want to cry. But then the amphotericin B came to the hospital, drug interaction, as I was telling you, even not only rifampin, but also the evidence in the ATRIPLA treatment that is the main treatment in Latin America for AIDS, the cost of drugs, the accessibility, for example, for liposomal amphotericin, and of course, the availability of primary prophylaxis for our patients. So itraconazole pricing is a concern, but especially the drug interaction. Now we got the itraconazole from the government to the patient, but still we have some problems. And that's why for us it's very interesting the opportunity to participate in the clinical trial MSGERC to see if this new formulation of itraconazole may help our patients. And fortunately, next year is going to be the second meeting of the group for advocacy for histo. It's going to be in Manaus, Brazil, in March next year. And what are the questions? What is the real burden of the disease in Latin America? We still don't know for sure. Now we have this paper that did the estimation. What is the best way to distinguish these 2 diseases? Definitely, I think it's rapid testing, but it depends on accessibility. What is the effect of this interaction, Histo TB? There is a lot of research, I think, behind this. And are there new drugs? Hopefully, we will be able to find new options, no? So definitely we need to decrease HIV late presenters, better diagnostic, and increase our treatment availability. And I would like to thank you, and I will be more than happy to answer any questions.
Good. Oh, thank you, Ana Belen. Thank you for talking to us. If you could, tell me, when we've visited you on 2 occasions, and I think the first time, maybe in 2015, you were relying on bone marrow biopsies primarily for a diagnosis of histoplasmosis, and then, of course, a lot of clinical suspicion. How have things changed with the access to the ELISA test? And can you quantitate how much more histo you're diagnosing, or are you just more certain of the diagnosis?
I think we are more certain of the diagnosis because we really were treating a lot histo empirically. And maybe we may have been decreasing by a 10% over-treatment of histo. And there may be also an extra 10% that clinically, there was no way I was going to think about histo, especially those co-infected with TB, and we may have been initiating treatment earlier. But we need to go to the data to actually be able to prove that.
Okay. And so do you have unlimited access to the test now? Are you using it liberally? I mean, I think you alluded to this, but are you using it in situations where you might not have used it before because you have access to the test? So is it leading to a lot more liberal use?
Yes.
Or is it still a very precious, tightly controlled type of
No, right now
type of
it's under a surveillance study. So
Okay.
we are supposed to test all the patients who fulfill the criteria, and
Yeah.
it will be fever and weight loss. You will get the test.
Okay.
Thank you, Anna, for the wonderful talk. You
Thank you.
did a great job, very informative. I have a small comment and a question for you. I think the comment is for our sponsors. I think you saw in Anna's presentation that there's thousands of undiagnosed fungal infections in Latin America, and the one investment we need to do in the region is diagnostics. If our pharmaceutical and diagnostic partners supported the region, this would be like a mine for clinical trials, and more importantly, we would be helping a lot of people. So I think the take-home message from your lecture is that this is an untapped resource for clinical trials, and that we need to build infrastructure to support this. The quick question that I have is, during your lecture you mentioned the thrombocytopenia, like it's something that everybody knows in the hospital. When you get thrombocytopenia, it's histo. Have you actually done any sort of research trying to look at the negative predictive value, positive predictive value of thrombocytopenia to help you diagnose it in a low resource setting?
No, we didn't. No, we haven't.
That would be an interesting study.
Yeah.
Anna, nice talk.
Thank you.
Some years ago when we looked at species and population structure in histoplasma, those Panamanian isolates were on their own branch. I wonder if you isolate histo from your patients, and if you do, if you type them, do they join that Panamanian group, or are they some of the other Latin American groups?
Honestly, we are not doing the typing of the histo we get, but from the study that was done by Dr. Witt there, he found out was class 5 and 6, the isolates during that study. But we haven't repeated.
Okay.
Right, but follow up to that. Since in our discussions with the director at the Gorgas Laboratories, that's one of the things we have talked about doing, is taking their stored isolates and comparing them to the other isolates from different regions. I think we know that they're distinct, but the question is it worthwhile doing that, or has it already been done well enough?
Hi, thank you for the nice talk. My question is about therapeutic drug monitoring. Is that something that you're able to do, or something that you are doing?
We are not doing any monitor of drug levels on these patients. It's mostly clinical.
Yeah, just thinking that especially important would be in this population with high TB co-prevalence. And
Usually people with TB will get the amphotericin B for long periods of time, instead of the itraconazole, because of that concern.
Anna, thank you for a great talk. One of the things that's illustrated in your talk quite nicely is the resource challenges that you face that we don't face here. Clearly, the importance of other things that we don't normally think about become paramount in your situation. Peter emphasized that with doing bone marrows to make diagnoses of histo. My question has to do with how much of the histo is related to AIDS. We talked a little bit about PrEP and its rejection the other day by most of your folks down there. It's either unavailable or they don't use it. If you were able to get ART, how available is ART with regard to cost considerations, et cetera, where you are too, if you could get very good treatment for AIDS where you are, or HIV, do you think Histo would be this significant problem that you face?
You are all right. We have access to ART. I honestly don't understand why people get so late and abandon treatments. It's for free, it's universal access, but our public health authority are not doing a good work, so I think that won't be the solution in the next 5 or 10 years. I don't think so. But we need to work on it. You're right.